So I've got 10 minutes to finish off this case. So as the previous presenter has showed, the two organs involved simultaneously with ischemic problems. Now here we have a single organ being involved with a clear-cut stroke with different stroke mechanisms. So the challenge was to decide what to do and how to tackle. So let's go. So this is a 54-year-old gentleman with no known comorbidities, except for a history of a permanent pacemaker implantation, which was due to a syncope attributed to a six-sinus syndrome. At that point, a paroxysmal AF was detected. However, his CHA2DS was 0. So he was discharged without any anticoagulation, which I guess is perfectly normal because he didn't merit any anticoagulation at that point of time. So coming to the clinics, he had an acute onset dense right-sided hemiparesis, presented to the ER 3 hours after symptom onset. NIHSS, large NIHSS, global aphasia, gaze deviation to left, which obviously raises a possibility of a large vessel occlusion, and transferred to angiosuit for EVT, and post-procedure his NIHSS dropped to 5. So let's see what happened. So this, as you can appreciate, is the dense MCA, and his aspect was 9, good aspect. So here, when we started the procedure, we found that there was this swelling, which we did not expect actually. So this is something which was not expected, and clearly the vessel had dissected. So atrial fibrillation in a patient without any need for anticoagulation lands up with a large vessel occlusion. We go for thrombectomy and find that there is a ugly looking dissection in the cervical ICA. So this is stroke mechanism number 2. So we have the MCA which is occluded. So these hardwares we used a Cerebus distal access, a Cat5, a headway, a synchro, and then we had to shift to a hybrid and a stent retriever. So this is a seemingly good lesion to do, but we have to circumvent this dissection, and in that day it gave us nightmares because this vessel was so badly dissected that the point of entry and the point of exit we couldn't figure out at that point of time, though we tried various maneuvers and various combination of catheters and all those things. So we were also not ready to go, so we tried from the contralateral side. So since we were not being able to cross the dissected segment in the cervical region, we attempted to go through the ACOM of the opposite side and try to retrieve the thrombus. However, that also failed. So we were about to give up. We thought that this was beyond us. However, we did a last try. So you see, this is the catheter tip, and we are trying to negotiate this loop. And this is a blind loop with a very small opening. And we were trying to push in and get out of this golok dhara, as we say in Bengali. And after various trials and various maneuvers, ultimately, we could see that the wire passes here, and then we could go into the segment which was above. So crossing this Chakravuho was very difficult for us, and we actually wasted a lot of time because of this pathology. So ultimately this was the stent retriever in place, and that was the thrombus which was retrieved, and we immediately had a good recanalization. For those who are not initiated into intervention, just look at the number of loops this catheter has made into the cervical ICA, thus telling you that what degree of dissection and true and false movement was made at this point, making life hell for us. So this was post-procedure, and we achieved a TK3 recanalization here, though we lost a lot of time negotiating that ugly dissection. Now here was the third question we had to solve on table. That this was a dissected segment. We had a thrombus which appeared here, went to the MCA, blocked it, which we have retrieved. Now, what about the dissected part here? So, do we do something about it? Leave it? Put the patient on heparin? Put the patient on antiplatelets? What to do? And on top of that, we expect a damaged parenchyma in the brain. So, all will be not perfect here. So, putting in a stent would immediately put the patient on a dual antiplatelet exposure, and there would also be a risk for a stent thrombosis. And as we will expect, that this sort of dissected segment is not easy for a stent to go in, so we might cause further damage. So we just left it like that and did a CT on the next day, which showed some amount of hemorrhagic transformation. So this was 24 hours later. I will show you the fifth day CT scan, second video. So the ICH which happened had resolved by another 4-5 days. So on the left side there is no major bleed, and this was the final infarct which developed. So if we recapitulate, this is a atrial fibrillation, innocuous, patient having a large vessel occlusion, prompting somebody to think that the atrial fibrillation has caused it. It was not. It was due to a cervical dissection that this thing has happened. We have retrieved the clot, left the cervical dissection as it is, and we are following up on the patient and trying to gauge what caused the dissection or what is it at all. So if you see the CT scan, this dissection is very well demonstrated over here. You can see the dissected vessel actually. Now if you pay close attention to the other side, it has an asymptomatic dissection as well. Okay. So both the large vessel on both the sides had dissection. One was a symptomatic one, the other was an asymptomatic one. So another part of the spectrum of the problem that this gentleman has. So this was the final outcome of the patient. The dissected segment, how it remodels in a 3 months follow-up. So if you follow the catheter, then this is through the vessel, through the dissection, and this is the dissected part, the true lumen and the dissected remodeled artery at 3 months of follow-up. So there is good flow, so we need not do anything about it at this point of time. So this is an example of how the vessel remodels. So this is the outcome of the patient at 3 months. Very good. So this is a case of a bilateral spontaneous cervical artery dissection. We did a whole genome exome sequencing. However, no pathogenic or likely pathogenic variants were identified for this dissection. So to discuss and recapitulate, emergent endovascular therapy without bridging thrombolysis was carried on for this patient. Optimal blood pressure management was done. Glycemic control was achieved. Antiplatelets, we were forced to withhold due to the spontaneous conversion of the infarct, and it was initiated on day 7 after signs of resolution of the hemorrhage. Strict adherence to the FACE protocol, which we routinely do for every stroke patient. Physical rehabilitation, discharge with single antiplatelet and statins, and a NOAC added on follow-up visit after 4 weeks. So now here comes the management part and the debate that what is the case? It's a post-PPM status, paroxysmal AF, not anticoagulated. So now if you go with the definition of a stroke and a background AFib, so obviously the answer is yes, you need to anticoagulate. But what if you know that the AFib is lying as a silent spectator? It is not the cause of stroke. The cause of stroke is the dissection. So you will shift your balance and say, okay, now then you have to give antiplatelets. So here, for the long-term follow-up of this patient, if the patient is not given any anticoagulation and the patient goes on having that AFib, you don't know that whether that AFib can be a cause of a dissection in the near future. And on top of that, you have bilateral dissections. So this is a now debate between a toast 2 versus a toast 4 scenario. So what would be the choice of secondary prophylaxis? So let's see. Acute ischemic stroke etiology, non-valvular AF, cervical artery dissection. This cause for antiplatelet or anticoagulation, and this is purely anticoagulation. So if we cancel the common thing, then anticoagulation I can use for both the scenarios. So like this case we thought we would present because this is a LVO with a not so obvious stroke mechanism. What appears as a culprit is not the culprit. We did a successful intervention which seemingly seemed impossible at that point of time, going through that cervical dissection part. Secondary prophylaxis is not so obvious. We need to think over, give a decent thought about it. Anticipate multiple stroke mechanisms and be prepared for a few surprises, even while dealing with sometimes what seems very obvious, AFib and stroke. So very obvious, no. And never give up, because that patient's life is dependent upon us at that point of time. So if my juniors did not push me that, sir, one more time, please see, I would have given up and I would have, let's say, okay, whatever happened has happened. So it was due to Shubhodip and Orpon pushing me that, okay, we will try it for one more time, that we were successful in bringing out a good outcome in this difficult scenario. Thank you. If you have any questions, please. Sure.
Thank you for a good lecture. Just what is the amount of burden paroxysmal fibrillation?
What is the amount of?
Burden of atrial fibrillation before going for. When you diagnose a paroxysmal atrial fibrillation, what is the burden? What amount of time it takes?
Okay, that was a paroxysmal atrial fibrillation which was detected when the patient was undergoing his workup for the syncope, which was due to the six-sigma syndrome. So he came to the hospital, he came to the emergency, and we knew that he had a AFib in the background. That's all.
Obviously, he had got one Holter monitoring 48 hours or 7 hours.
Sir, the patient comes to the ER and he has a discharge summary which is written that he has a background risk of AFib. That's all.
It is not mentioned that what amount of atrial fibrillation.
No, not at that point of time. It's a rush.
The duration of AF burden is important for deciding treatment whether it is anticoagulation or not. We are giving. That's why I am questioning.
Yeah, but still with that, he has a charge wasp of 0. At that point of time, his charge wasp is 0.
No, charge wasp is 0, but if the burden of AF is one of the important factors. Whether it is 30 minutes, 5 hours, there are a lot of opinion about that. There is no consensus about that.
So even,
but there are some views that more than 30 minutes is there, then we should go for anticoagulation.
Even if the charge wasp is 0.
Yeah.
Sure. Okay.
Very nice presentation. Suppose if it is a long kind of dissection and it extends intracranially, so is it still safe to use anticoagulation, or in that case you will try antiplatelet?
No, we have waited for that thing to settle.
Yes.
And then for anything, if it's not a bleed, so dissections can present in two ways. Either it's an ischemic complication or it's an hemorrhagic complication. If it's not a transmural dissection, which causes an hematoma, then you are allowed to use whichever agent that you wish.
One thing I want to know, Deep, hyperdense MCS sign. If you see hyperdense MCS, then can you say that it's due to obstruction? Because in hypercoagulable state also there is hyperdense MCS
Not
sign.
always. You have to match the scenario. Like the patient comes to you with a hemiplegic syndrome and you have a dense MC. Obviously, you are thinking that that is a culprit lesion. But often, if you see the routine scans, someone with polycythemia or somebody with a calcification might have a hyperdense MC false. Thank you.